go ahead and start, Kevin?
Yeah, that's fine. So as a reminder, *# will mute your line and unmute if you have anything going on there. And next slide, please. Next slide, please. And we wanted to remind you about our Molina Healthcare partner, who will give you reimbursement if you come to one of our clinics that does case consultations, and it's a Molina patient that you have and you consult on them, you can get $150 from Molina. And contact us for more information about that.
I might add that we are encouraging the other managed care organizations that have provide the Salud health care for the Medicaid insured patients and students to also offer this $150. It's really an incredible opportunity to get on the phone and present a patient and get a consult from a lot of experts in the room, and then you get $150 back to your practice. So keep that in mind. So I'm going to be talking about some basic principles of coding, primarily using some case examples that I'm bringing from the world of school-based health centers. And in the last several months, I've been keeping my ear to the ground about providers and people working in school-based health centers and some of the questions that they've had over the last few months. So I'm hoping to answer some of those questions. So our objectives are just to review some of the American Medical Association coding, the CPT and ICD-9 huge manuscripts that they produce every so often, and then increase our knowledge of the Medicaid Scope of Services in our school-based health centers here in New Mexico, and then hopefully have you learn or identify 2 benefits of improving your coding. So some of the questions that you should be asking yourselves, and whether you're a provider or a clerk or a medical assistant, I'm sort of lumping everyone together as a provider in this presentation because I know that the medical assistants and some of the coordinators are also involved in documenting a lot of things that go into the claims. So as a program, you should know if your claims are, how they're getting processed, or if any are getting denied, and if so, why not. And also that your documentation supports all the claims or the encounter forms that you send in to Medicaid. And then does your charting, if you do a medical record review, does your charting represent the quality of your care? Specifically, we're going to be talking about a modifier that is very useful in school-based health center work, as well as coding for time, and then looking at your reimbursement rates as well. I also, just to alert you, one of the attachments, I think, Kevin, is an old coding PowerPoint that I did. It's sort of a vintage PowerPoint.
Vintage PowerPoint.
About coding. I just included that because I don't want to spend this hour in really going into little details about how you code. If you've been working in clinical practice, you pretty much have that basic knowledge. So I'm hoping to really use this time to talk more about what it's like in the school-based health centers. But just so that we're on the same page, CPTs are the current procedural terminology. It's what produces your visit data, describes your procedures and services. It's what you did as a provider. And the ICD-9 is the International Classification of Diseases, 9th edition. And it is the diagnosis, descriptions of diseases and injuries, sort of why you did what you did for the patient at that time. V codes are a supplemental classification of factors influencing health status. or the patient's contact with health services, or sometimes descriptions of conditions when there is not an exact disease process, but there is a health condition or a risk condition. Often it's the V code that you'll be using. And medical providers use ICD-9s and V codes and CPTs, and the V codes and diagnostic codes can be used in a primary position on the encounter form or as secondary, and it just takes time and experience to figure out how to do that appropriately, I think. The main thing is that your CPT code and your diagnosis code need to link appropriately. If you see a student for a sore throat and somehow or other you put in a diagnosis of depression or a well child check, it doesn't link. They need to be connected, okay? Because that'll, when Medicaid does a review, or your billing group does a review, and they say, this doesn't make sense, this doesn't match up, and that they might deny it just on that basis. For behavioral health providers, V codes are a little bit different. There was a behavioral health purchasing collaborative in 2010 that really specified the V codes, and the V61 series are primarily for let's see, they're all counseling codes, all different types of counseling, and the 995 series are child and adult abuse and neglect codes. So I don't know if we don't have any behavioral health providers in the audience yet, but it's really just particular to them. Again, we're all using in school-based health centers in New Mexico that are funded by the Department of Health. We're all using one encounter billing form, and that is also an attachment in what we've provided to you. We also I'm trying to speak to all sponsoring agencies that run school-based health centers in our state, the federally qualified health centers, the school-based health centers that are sponsored by the universities, and the regional educational cooperatives. They're all different. The sponsorship and governance of school-based health centers really has a lot to do with how your encounters, how your billing and claim forms is being processed. So, for example, the federally qualified health centers, the FQHCs, they all have electronic medical records. Most of them have eClinical Works, not a majority of them have eClinical Works, and they're because they receive federal grants, they pretty much have one reimbursement for every visit that they have in an outpatient setting, whereas the universities and the regional educational cooperatives have more the traditional type of billing and reimbursement that a doctor's office would have or any outpatient clinic would have. The important thing is that all of the entities should be documenting the CPTs and the ICD-9s to really demonstrate the work that was done and the services that were provided.
So could you give us an example of the difference? Say, for example, I take my child for a sports physical to an FQHC. How does that look different when you said they have an overall thing,
well,
and the school-based...
Sports physicals are an exception. Let's say...
make an easier one.
I think as I go through, you'll see the differences because they get a universal payment no matter what they do. They don't bill for time. They usually don't bill for... it's mostly billing for time or using modifiers. They generally don't do that because it doesn't matter. They're going to get the same fee, the same reimbursement.
So if I took my child in for knee pain to an FQHC, they would get paid X number of dollars regardless of how much time. And if I took
Right.
my child to the school-based health center at an REC for knee pain, they would have all those things delineated
Right.
to end up.
Right. There's just much more documentation that seems to happen for, not saying chart documentation, I mean as far on the billing side of it. Okay? Some of the challenges that, and I think partly it's because the electronic medical records has issues with, has an impact on your practice. But, and all of us in school-based health centers see so many minors that requesting confidential services that it's really challenging to make sure that your charting and your billing doesn't jeopardize that confidentiality. So with many of the EMRs that the FQHCs are using, the only way they can in the EMR system is to PSAC, which is called patient. I just wrote it down. Patient Security Access Code. It's a section in their EMR that they can lock down, and they can put protected notes in that. The other way to sometimes maintain confidentiality is that they have a section that they can, it's called a telephone encounter, and in that they can sometimes put notes and things like that in that section. You could try and put your STI, testing for chlamydia and gonorrhea, but with the patient portals and parents being able to go in and look at their child's record, they might not be able to get into that PSAC, but they could get into the lab. So, and they could see, you've ordered a pregnancy test, you've ordered a STI screening test. So that's all areas that are really at the forefront right now with patient portals and pediatric practice and confidentiality. So there's really I can't report any new solutions to these issues. It's going to take a while for all of this for people to figure it out. But I did learn for FQHCs that if they go into the e-prescribing section, that's where they can also ensure that labs, medications, and referrals could be documented there and they could be kept confidential. The other rule that happens when you have, so this is not just pertinent to FQHCs, but when you have an electronic health record, that you cannot, anytime you enter a visit in your documentation of your notes and your diagnosis, you can't have two types of visits for the same patient on the same day. It's called double dipping. Medicaid will catch that, and you can only get paid for one of those notes, one of those visits. And it seems in an EHR that's really hard to do, because you've got to chart the confidential visit in one area and the non-confidential in another area. It looks like double dipping. So the advice that I've learned from the Primary Care Association, from at the university, the medical group, is that you really have to prioritize. If the student comes in for a well child check, but they have a confidential request, they also want a pregnancy test, they also present with some risk for depression, and they want it confidential. Well, don't go ahead with the well child visit. Just deal with, reschedule that well child visit and deal with what the chief complaint, the chief problem is that the student presents with, and then bring them back for the well child check. That's the only way that we can ensure confidentiality and also make sure that we're documenting all the details of that kind of visit. I've had questions about what is the difference between a primary and secondary diagnostic code, an ICD-9. Primary diagnoses are the reason for the visit. So it's a well child visit. that's the visit, you're going to have to use V20.2. But it's also the primary diagnosis is when what the patient comes in with their chief complaint or their chief problem. So sore throat or dysmenorrhea, painful menses. That would be the chief complaint, the main reason for the visit. That's a primary diagnosis. The secondary diagnosis is other conditions, other findings that you come up with during that visit. So it could be that it is a well-child visit and you put V20.2, but they also, in reviewing of systems, talking about family history, having them complete the student health questionnaire, these other things come up about family disruption or need for family planning counseling, things like that. Those are your secondary diagnoses. So dysmenorrhea could be your first one, but then maybe your second one on that visit would be family planning or contraceptive advice, the V25.09. So the main message here is to document as many pertinent ICD-9s that you cover, that the patient comes in with and that you address. If you don't put everything down, when you really look at, you're the coordinator and you want to do a printout of what are our top diagnoses, and your providers are only filling in that one spot on the billing sheet, you're really not getting a good overall picture of what the practice is like. This is a section of that Medicaid School-Based Health Center Encounter Form that is an attachment that you might have already accessed. So we're going to be referring back to this as we go through. Also, just let me back up a little bit. Just remember that depending on your billing system, and you're using this form to document your claims for the visit, if it's a confidential visit, make sure that you're documenting that somehow in the claims form so that the billing people know that if it's a Medicaid insured child or minor, there won't be an EOB sent out, so we don't have to worry about that. But if the patient has private insurance through the parent's health plan, private or a commercial health plan, and that your patient you're seeing in the school-based health center is covered under that health plan, and you have a contract as a provider with those health plans, and this bill goes out, the EOB will go out to the family. So it's really important to not bill those visits, or unless they're Medicaid. If they're Medicaid, then Medicaid here in New Mexico does not send out a claim form. So EOB, explanation of benefits, will not be sent out to the family. So just a reminder about that. I think most people know that. Also, looking at that encounter form, you'll see that there is a 99211. It's a minimal 5-minute, usually a 5-minute visit. This is not a code that a medical provider should hardly ever use. This is a visit that is generally a medical assistant visit, a nurse visit. It states in the definition of this code that a medical expertise is not necessary for this kind of visit. So it's rarely used in school-based health centers, but I have seen it used when there are standing orders, or now, if there's a standing order, the provider says return in 2 weeks for a weight check, it's, with the medical assistant, with the nurse, fine, go ahead and do that. The provider still has to look at that chart, still has to sign off on that. So because nurses alone, medical assistants alone cannot bill, but they can do the activity. They could check the flow meter reading for an asthmatic. They could do the blood pressure check, the weight check, whatever it is that's going to take 5 minutes or less. But the bill, the claim, still has to go under the provider name. So the provider still has to look at that note and sign off on it. Okay? So let's just get into some of the cases here that I hope will demonstrate sort of the typical care in a school-based health center. So this is a 15-year-old patient who presents with acne. It's a new patient, so you're required to not only take the history of the present illness, but also review the review of systems and the past family and social history. You must do at least a general assessment of the patient, and you're just really, the chief complaint is acne. You're really just going to look at one body area, the skin. And your medical decision is pretty much just problem focused. You make your diagnosis, you discuss skin care, you write a prescription for acne. So it's pretty straightforward. If you look at the encounter billing form, it's problem focused. It's a 10-minute visit, generally. And your ICD-9 is 706.1, which is grade 2 acne. But in a school-based health center, this is their first visit, so they really also need to complete the student health questionnaire. The provider needs to review that with the patient, sign it, make their notes, and date it. You have a second CPT of T1023, and that T code can be scored, reviewed, and interpreted by either the medical or the behavioral health provider at the school-based health center. So you've got 2 CPT codes and the previous diagnostic code of 706.1, okay? So you would have 2 CPT codes totaling, what is that, about $47, okay? So any questions? If you have questions or comments as I go through these cases, feel free to speak up. This is an established patient, comes in, so this is a patient that has been seen before, or it's been 3 years, that 3 years have elapsed. So there's a new patient, never been seen before. There's an established patient that has been seen previously in the last within the last 3 years. So if you see the 16-year-old when they were 12 in mid-school, more than 3 years have gone by, that's a new patient. Mm-hmm. You have to repeat the whole exam, review a system, family, social history, the whole assessment.
So my question when you said 3 years is we got stuck in the HIPAA-FERPA discussion last year. So didn't it, for those sites that were not FQHCs or university run, they ended up getting into this, everybody's a new patient again because... Oh,
with the new
so
sponsorship.
I don't know if it's worth saying that out loud again.
That's true. Sites that were sponsored by, who were they sponsored by?
The schools.
By the school districts. Seems like ancient history.
It's not.
So the school districts were sponsoring school-based health centers, and there was this HIPAA-FERPA issue. So then the regional educational cooperatives came in and took over the sponsorship so that there wouldn't be this issue that the school records, health records, and the medical records could not be shared when it was run by a school district. So yes, when they become part of a new practice, a new sponsorship, they all became new patients again. Yeah, that was...
So it made a lot of extra work.
A lot of extra work, exactly. Okay,
Paula,
so let's go back. Go ahead.
This is Linda Filippi in Mountain Air. When I talked to Apex about that early in the year, they actually said that we were supposed to continue as established patients.
For the claims, really?
Correct. So the records have just continued with the Apex records.
Okay, so that was with Welligent.
Correct.
Okay. Well, so they
so that was. It sounds as though that was not the correct way of doing it, but that is how, at least in this center, we were directed.
Okay. Well, Linda, don't go backwards. I will.
No, I'm not going to. I'm not going to.
I will. Maybe that's something that I just wasn't aware of. I will check back with Apex and just check on that. But
so maybe I'm wrong in asking the question. So, Linda, this is Kirsten, and you know everything down there. So we definitely don't want you to go backwards. But I'm wondering if the issue
we don't know everything.
The issue is less about Welligent and more about access to the records. So I'm thinking about the sites who had to give up their records. In other words, they got locked somewhere and they couldn't see them, and they got they had a turnover in providers, so that the whole systems knew, the coordinators knew, the MAs knew, the behavioral health providers knew, the PCPs knew, and so they don't physically or have any contact with these students before, so they are new to them in the sense that they don't have any institutional memory, and they also don't have access to the records because they were run by that other entity are not available.
They don't have access to the charts, but they do have access to Welligent. So the information that was put into Welligent would be available to them.
Good point.
Okay. Well, that clears it up. Thank you, Linda.
See, I told you knew everything, Linda.
No, I don't, not hardly.
Okay, so let me just move on.
Sorry, we got you off the track.
That's okay. But let me just catch up here. The main thing on this patient is that it wasn't just a simple pregnancy test. Other things came up regarding the relationship with the partner, and during the exam, a lot of symptomatology came up as well. So it was more than, you're going to prescribe Plan B and contraceptives, but because this was more complex, it was not just a problem-focused visit. Because you had to spend more time because of the behavioral health symptoms. You went ahead and upcoded to the 99214. Generally, if this would have just been, we're going to make sure that you don't have an STI, and here's Plan B, that probably would have been a 99212. But because of the anxiety, sleep disruption, and the amount of time spent, you have the same CPTs. I mean, you're going to choose a higher level CPT, do the pregnancy test, send off the STI, the urine for the STI screening, and then have them come back. And I'm going to talk more. Oh, here's the piece about time. So actually, this was a detailed visit based on time because 50% was spent in counseling. And your reimbursement is going to reflect that more complexity and more of the expertise of the provider. So that reimbursement would be $79.45. What has to be in the chart, whether it's an EMR or paper chart, is you have to document that more than 50% of this 30-minute visit, or let's see, usually for a 99214, it's about a 25-minute visit. So more than 12 and a half minutes of that visit. So I would put 50% of this 25-minute visit was spent counseling and courting care regarding family planning and STI prevention, something like that. So that has to be in there. What's interesting is what I was saying earlier. If the patient presented with just straightforward, I need a pregnancy test, I want to be tested for STIs, that would have been a 99212. It would have paid $36.89. Could have been a 99213. It would have paid $50.52. It depends on the complexity and the time and the medical complexity of the visit. And providers just have to document that level of complexity for their coding. So this patient, again, it's family planning. This is symptoms of, again, depression, but there is no suicide ideation, no risk to others. So the provider, besides the SHQ, also administers the patient health questionnaire. It's 9, PHQ 9, which is an assessment tool to assess depression, and scores that, goes ahead and does the physical exam, including the mental status exam, does a lot of counseling, goes ahead and prescribes the contraceptives, but refers to the mental health therapist, behavioral health therapist. Make sure that she's put that in the referral log, that she's made a referral. She has 2 CPT codes now, one for the visit, one for the PHQ-9. Her diagnosis code of 309 is for depression. The V25.01 is for the family planning. Okay?
Would you add the SHQ on top of the PHQ-9, or does that supersede it since you've decided to do, if this were the first visit?
If it was the first visit, I
You'd
would.
still add it?
I would still
Even
add
though
it.
you went on to an assessment tool?
Right, right. Now, the PHQ-9, at this time, only the CHIPRA sites are getting reimbursed for that 99420, but I think very shortly that will open up to all sites, whether it's administered by the medical or the behavioral health person. So this is another example of that referral, the PHQ-9 was done by the nurse practitioner, but referred to the social worker, who goes on and assesses all of that and does more in-depth behavioral health assessment, does a 15-minute visit. And I put this in here for behavioral health providers because of the new crosswalk that happened last year. Let's see, it was August of, when was it? I'm not sure. August of 13, January of 13, I'm sorry. So some of the behavioral health codes have changed, and this is a new one, the 90791 TR. And then she's got the diagnosis code of depression, and discovers also that there's marijuana use, so that 305 is for marijuana use. And then for any psychiatrists that look at these slides, they would also use the 90791 or the 92 for their charting. And again, this also just gives the information about the independent licensed therapists who can use these codes. So the LPCCs, LISW, PhD psychologists, clinical nurse specialist in psych, and psychiatrists. And then the 2 behavioral health providers that need supervision and signature for the billing. There is a case management code for behavioral health therapists in school-based health centers. It's a T1016-TR, and it is really critical very often for behavioral health providers to not only confer or coordinate services with the medical provider in the school-based health center, but also within the community and the school setting. So this T code was added to our scope of work in school-based health centers for the time that the social workers, behavioral health providers spend in researching, talking to community support services, and sometimes those are within the school. They could be talking to the social workers in the school. If this is a special ed student, they may be talking to the special education coordinator. They may be doing classroom observations. All of this is, to coordinate care, and that's why for school-based health centers we have this code for those particular providers. It does not include in-person or phone conferencing with parents or families, but they have other codes they can use for those sessions when they're face-to-face. I'm sorry, I'm being trying to keep track of time here, and I want to make sure that we get through some of these cases. Again, this is a behavioral health visit, and probably, again, they're using the new code, the 90791. This is more of an assessment or diagnosis for anxiety, and V62.3 is the V code for poor school or academic performance. And then this is the opportunity for that therapist to then refer this patient to the medical provider at the school-based health center, because you always want to have a holistic approach with students who present with medical and behavioral health symptomatology. So the medical person should also see this student to rule out any constitutional or medical reason for some of these symptoms. And again, document that referral. Let's move on to the well child office visit. Again, new patients, established patients. The V codes are the same unless they're at 18. They go up. They use the V70.0 instead of the V20.2. But the CPT codes are different based only on whether they're new to the practice or they're an established patient. So here is a EPSTAT new patient. So based on age and that she's new, it would be a 99384. And then of course, new patient, she's done the SHQ, so add that. But notice that her BMI percentile back there was above 95. So I inserted this little chart because it's very helpful I would tape this on every work desk in the school-based health center or on the desktop so that we have all these weight category diagnoses documented. So this, because it's not the chief reason for the visit, it's a wellness visit, you would use a V code for this, and at the top is the BMI percentiles, or, that's the place, the 85.55 is the place setting for the BMI percentile, but it takes 4 digits, so you have to say, well, this student was over the 95th percentile, so her V code is V85.54. Now, if you were seeing this, well, we'll get to the next, that'll come up in the next case. But because she has a diagnosis separate than the wellness exam, she has another abnormality, another illness that is separate from the wellness exam, you can use a modifier 25. And you go back to the visit codes, the 99201s to the 99214s, and what you actually do is you also bill for the obesity. So you would, because the obesity requires additional documentation of the history, further physical exam, more complex decision making, and you do a fasting glucose. That, she hadn't eaten that morning, so you can do a fasting glucose. The key thing is that you have to chart in two different places. You have to actually turn the page in your paper chart and make another notation, or in your EMR, you have to open up another template, another page in your EMR, and chart it for the V85.54 for the obesity. And then put in that note, you're not going to use the V85.54, you've used it in your wellness exam. In the 99213, it is the primary reason for that visit. It becomes a 278.00.
On the second page.
Right. So that would become your primary code for obesity, right? And then the 701.2 is the acanthosis, nigricans, that was also evident on that exam. Okay? Because it fits with the obesity, the acanthosis. And make sure that there's a separate note. So the actual billing form would be 99384. The ICD-9 would be V20.2. The second would be on, you would check off on your billing form the 99213-25, add the ICD-9s for that visit as well. And then you get reimbursed for both of those. I don't recommend that you also do all the nutrition and physical activity counseling at that visit, because you're way over the time that student needs to get back to class, but have them come back and finish up the best practice for students at risk or who have obesity, and start working with them using your motivational interviewing skills to assess nutrition and physical activity and come up with a care plan with them. Okay? Yes?
We do have a question from one of our participants. Back to the issue of not seeing a patient for two types of visits on the same day. If a patient is there for an EPSTAT, EPSD-T, and an STD screen is done, or there is a conversation regarding confidential matters, how is confidentiality protected in notes, or does this warrant two visits?
It definitely may be like that first case I talked about. If it's a Medicaid patient, go ahead. There's no risk of confidentiality. If they're not Medicaid and you are an FQHC, where it's really hard to separate out that you did the same work at the same visit, the same time with the patient, you have to separate it out, take care of the confidentiality piece, and bring them back. I've talked to Primary Care Association about this for 2 days, and this is the only way we can figure out how to do it and safeguard the confidentiality. So I hope that answers that. And I've already talked a little bit about this slide, making sure that your providers are, you as a provider, or the coordinator or the medical assistant, whoever is, putting in all these codes, that every code is entered into the claim. And it's really important when you are doing a medical record review and you're looking to make sure not only what is the picture of your practice, but if you're looking at are you meeting some of the best practice indicators and tracking the HEDIS elements. If you don't code them, that means you have to open up every chart and look at it. If you code them, then you know what charts to pick up and go back and review. Any comments from Deborah or Linda on that?
No.
Okay, all right.
Hey, Paula, actually, yes. I do have a comment about, that was my question about the guarding confidentiality. And I can understand if it's Medicaid in terms of an EOB not going out, but if a parent wants to see a chart or wants access to a chart for the EPSAT, right, and you have an STD screen written down on there somewhere, that would compromise confidentiality.
Well,
right?
If you, let's go back to this. We're talking about this case. No, we're not talking about this case. I don't know which case we're talking about here.
Well, this one was just one I was.
Okay.
I mean, we have every day. We have
right.
situation.
Right. What the provider could be doing is chart on one page the EPSDT, the wellness exam, and chart on the next page the next progress note, and make that page confidential. Mark that as a confidential.
Okay.
Then you
because I think what we've been doing is we've been actually making the EPSAT note confidential, which it's not. I mean, which it wouldn't be.
Not.
I mean, it is, but it shouldn't be, because a parent should have access to that.
Right. And the confidentiality, you're just by utilizing the SHQ, you're getting into some confidential areas.
Right.
But you are not providing confidential services. So, you know, every pediatrician following Bright Futures guidelines and doing anticipatory guidance with an adolescent, you are required to assess those risk factors. Once you provide confidential services for identified risk factors, that becomes the confidential piece. That's separate charting, separate treatment plan from the wellness EPSTAT.
Okay, but
paper chart, that's easy. Go ahead.
Right. No, I was just going to say, but that could happen on the same. That could happen on the same day that we do the STD screen and the, you know, I mean, it has to. So, okay, good. Thank you.
Okay. All right. Sports physical. Actually, Kirsten brought up this issue last week and here in the office. And every spring, every school-based health center seems to have this question come up. When can you do a sports physical and have it count for the fall sports? My rule of thumb is we don't do sports physicals, we do wellness exams. We do EPSDTs, convert all your sports physicals to EPSDTs. If you have to do a sports physical, then use the New Mexico Activities Association form. Ashley, one of the health plans, will pay you more if you use that form and document that you've used that form. I think that's Melina again. Hopefully, I think we're working for all the MCOs to honor that. Because the New Mexico Athletic Activities Association form is pretty thorough. It's really a full exam, and for the athlete, it's listening to doing a cardiac exam with the student lying down, sitting up, standing, the whole, you know, skeletal, musculoskeletal exam. So it's pretty complete. But what we see happening is that if you use that form, it's really that last page where the provider signs off. That's the piece of that form that can go back to the coach. Do not give that to the student or the parent, say, oh, just turn this all in to the coach. That is a violation of HIPAA.
Guess what happens?
And it happens all the time. And small communities, small school-based health centers where everybody knows everybody, it's just not acceptable to do that. Just that last page needs to go to the coach. And that's the page that says, yes, they're cleared for sports. Yes, they have an allergy that you should be aware of, and nothing else is their business. So it's one of my pet peeves that I see that when I see that happen.
Paula, can you say that again? Because I've got a sports physical form right here in front of me, and and we were having this discussion today. They're asking the same information on both of these forms. So you're saying only the one that says student is cleared for all forms of sports should go back to the coach. That the one that says everything is normal doesn't?
Doesn't. Because Is this the one? Is this the form you're looking at? Is the New Mexico?
Yeah. Yes.
Okay. All right. Some of the school districts are still using their old school district forms, and they're not up to date. So that's one of my other.
I think
the other challenges is to make sure that your district is using the most up to date, approved form.
I think they all, even the district ones, still have that final page that's just
Yeah.
what you're describing.
Right.
But I think a common problem, Courtney and I were talking about this too, that they're on the athletic director's office or the trainer at the school. They just get stacked up in a box, so there's no protection for any of
Right.
that at all.
They're not locked up, and anybody can look through that stack of information, and privacy is breached. So
I'm not talking about the first form that has all the questions about has your doctor ever denied or restricted your participation in sports? Where all the little check boxes are. The next two forms, one says clearance form and the other one says athletic participation physical examination form. So you're saying this physical examination form where it says appearance, eyes, ears, nose, and throat, and there's either normal or not normal.
Mm-hmm.
That's the one that I've been given to the coach, but that's the one that should not go to the coach.
That should not go to the coach. It's the it's the last page the last page where the provider signs off and says cleared for or not cleared for is what goes to the coach.
Okay,
there's two places for the provider to sign off.
Right.
Yeah.
Okay. And I mean, we've been giving them the entire form.
Mm-mm. Well, hopefully they're locking them up, and they're not telling, because on that form, I think in your school-based health centers, if your providers are filling out that form, they're more knowledgeable and more careful about what they would put on there. But students coming in where, the provider could write down the antidepressant they're on, they could write down, family history, there's just so much potential to write down confidential information on there. And we're in small communities. It's
right.
It's really, the coaches, they're not health providers. They're not, they just, once they get the clearance from the medical provider, that's all they need. They
don't need the form that's got the blood pressure on it.
No.
Okay. No. Well, good.
So just one page, the last clearance form, that's it.
Yes.
Well, that makes sense because we couldn't figure out why they were asking the same questions twice.
Right. It means the provider has to write it twice, but there's a reason for that.
Okay. Well, I was writing it twice anyway, but I was giving them, the coach, both copies.
Okay.
Yeah, us too. Okay, good.
Okay.
Yeah.
And then just to finish up here, that the New Mexico Activities Association says that any sports physical or EPSDT done after April 30th is acceptable for all fall sports. But
we looked it up, and it's now April 1.
Okay. I will definitely. I can't change this slide right now, can I?
Oh.
Yes, you could actually.
Whoops.
Paula.
Yes.
So this is
Sean. Last year, Ken Barres, head of athletics at APS, told me after April 1, they were good for the next year.
Okay.
Yeah, and I think I've heard April 15th too. So.
Can I do it now?
Well, we looked it up on the web, the New Mexico Athletic website or whatever they call it, and it's April 1.
Great, okay, great. Thank you.
And I found the form too. I don't know if you want to go over it, but we could put it up there so they could look at it. We found that last page.
Now I've lost my place, Kevin. I don't know what slide I'm on. But okay, April 1st. Now we've had recently. How do I get that? I don't know where, there I am. We've had a nurse practitioner refuse to do a sports physical at this time because best practice is to do the sports physical within 2 to 3 months of when they're going to participate. I think the provider didn't realize that this athlete was already on the team and was going to be starting practice in July, and so it was quite acceptable to do the sports physical this month because they were going to be practicing.
Yeah, cross country.
Cross country,
football,
soccer, football, whatever it is. So that's why I put this slide together, because it seems that we do, you don't want to do a sports physical for a sport maybe 6 to 8 months from now, because a lot of things could change for that in that student's health status. But 2 to 3 months before they're participating is quite all right to do the sports physical, and that just happened this past week, so it was very timely to include this.
Well, what about the student who you do the sports physical in July or now, because he's going to start football practice in July, but then he's also using the same clearance to do basketball in whenever basketball starts. That's a spring sport.
Right. Personally,
do we need
I will have to look that up. To be honest, personally, as a provider, I wouldn't do that. I'd have them come back. I would review that previous sports physical. I would particularly repeat the cardiac exam, the neuro exam, the musculoskeletal exam, and just update it, and check the blood pressure and BMI and things like that. I wouldn't just clear it again.
I would if I knew that, and if the student comes back, but the students don't come back. They've got a sports physical form. The coach thinks it's good for a year, the student thinks it's good for a year, and you never see them again until they want a new one for the next year.
Okay. Well, this is something
maybe that's not something we can address. Maybe that's the athletic association that needs to address this.
I think so. I would be happy to follow up on that and see what their current allowances, recommendations are. I do think you're right, though. I think they can use this sports physical for winter sports. But let me double check. Courtney, do you have an?
I know that they do it twice a year at the high schools and the college, and it's just when you're transitioning from one sport to another, in order for you to actually go and even do tryouts, like for example at the high school level, you have to go see your athletic trainer and and then see your provider.
Okay.
To continue on to your next sport.
Okay.
That's my experience with, but I mean, some smaller areas, rural areas, just do like the 1 a year thing.
Yeah.
Because there's a resource issue.
Yeah.
But I know that
Colonel Leo is not asking for 2.
Yeah, Nair does one.
Okay.
Yeah, we do it. I've done it twice a year in high school and college, though.
Okay.
Yeah.
Thanks, Courtney.
Paula, I would like to just go back just very quickly to what we turn in on the first page of the NMAA sports physical form. It asks that the entire packet be sent back to the athletic department.
And that usually goes back to the athletic trainer who divides.
Who divides it?
Who divides it.
Yeah, please answer all health history questions on the following page prior to your visit to the doctor. Please fill in the student's athlete's personal information on each page of the form and return the entire packet to the school's athletic department.
So then the relationship that typically happens there is the physicals happens, the patient sees the provider, and then the provider signs the yes/no.
Mm-hmm.
That sheet goes to the coaches via usually through the athletic trainer or whatever, and then the rest of the information stays with the athletic trainer and a copy goes to the provider. And so that information should be locked up. all the medical stuff, and just that one
Oh, so they
sheet goes.
separate.
That one sheet goes back to the coaches. So we make a stack of this goes to the coach, and then this goes to the athletic trainer and the doc.
Okay.
So what they're asking for is that the entire packet go to the athletic department, not necessarily to the coach, but to the department.
Yeah, they should clarify
Yeah.
that
Should have been-
statement.
yeah.
It should be athletic trainer and provider, not just department, because
Right.
that encompasses the coaches and all the
Well, in some
support
of
staff.
these rural sites, the trainer is the coach.
Exactly. Right.
So-
Yeah. Exactly.
Yeah. Yeah.
Yeah.
Okay, I'm going to redo this slide. but good discussion. Okay. Can everyone stay on for a little bit longer?
Yes.
Okay.
Sure.
And really, I will update this slide and send it out with Courtney's help back to everyone. So the only other important thing I think with school-based health centers is that very often there are times when these prolonged service codes are used. 99354 times 1 is for an additional 30 to 74 minutes of face-to-face time. And what has happened, and I've actually experienced this, I'm sure Debbie and Linda, you have too, that a student presents with an acute episode, and the student has history of asthma. And so patients in distress, and the nebulizer treatment is started, and the patient is monitored either in the exam room by one of the staff at the school-based health center. It doesn't need to be face-to-face contact with the provider, but it's intermittent contact while people are, getting a hold of a parent, deciding, the provider's deciding, further treatment. The action plan is updated, and this takes a lot of time. To follow up appointment, get in touch with the PCP. So to document and code and get reimbursed for that time, the use of this 99354 is used. So you'd use your usual CPT code for the visit, but then add the prolonged code visit along with the nebulizer treatment. And then remember, if you're using stock from your pharmacy, the albuterol, the NDC number, so you can get reimbursed by Medicaid or the health plan. So it isn't frequent, but it does happen. Have you out there experienced any other time that you've had extended or prolonged face-to-face visits?
Oh, yes.
Okay.
Many times.
Is it usually, with this kind of situation, or with this behavioral health crisis, or?
We've had both behavioral health and we've had alcohol intoxication.
Ah, okay. Good examples, and it's sort of disruptive, and it takes the whole staff's attention, but a lot of people think that the provider. I want to just make sure that people realize that the provider doesn't have to stay in the exam room with this patient the whole time. The team can take care of it, because you probably have another student waiting to be seen, and they've got an appointment and they should be seen. So there's some juggling that needs to happen. So just any other questions? We will do roll call just to make sure you get your certificates. So Kevin, you want to?
Yeah, so anybody who hasn't announced their name, please go ahead and do so.
Well, it's Sean, but I got on late, so I don't think I should get the whole credit.
Yeah, sorry, Sean.
Mary Johnson. I'm here, and I've just been on the phone.
Hi, Mary. And I did get your email.
Okay,
So I'll
great.
follow up with you on the problems you were having getting on.
Okay, thanks.
And please, review the vintage coding PowerPoint I included and the encounter form.
Yeah, I have it open. I couldn't connect for some reason.
Okay, all right. On the encounter form, the T1016 is on there, and the T23, and the 99420. There was Medicaid sent out an encounter form prior to the one that I have included, and it did not have the T1016. So that's why I made a point of including the current one on the handout. Because I think some of the behavioral health providers thought it had been deleted, and it hasn't. So. Okay, we're going to do another webinar on coding. I'm going to try and concentrate more on the advanced, more of the HEDIS measures, more of the advanced situations that we see in school-based health centers, and go into more detail about STIs, immunizations, pediatric overweight, and maybe some more about depression, just the ins and outs of best practices, as well as making sure that the documentation and the coding and therefore the reimbursement is appropriate. So thank you. Thank you very much.
And Paula, that's going to take place on May 1st, which is a week from tomorrow, same time, 3 o'clock.
And this one has been recorded, right?
It has.
Okay.
Yes.
Thank you. Thanks, everyone.
Thanks, Paula.
Thanks, Paula.
You're welcome.